All right, Robyn, you there?
I am here.
Perfect. Well, today I'm excited to have Dr. Robyn Knudsen-Bouling, who I guess I've known since I've coached her son many years ago when he was not a big grown teenager. And I've had a lot of very similar kind of thought processes as Dr. Robyn. She's also been one of my doctors through some injuries. And today we are going to pick her brain a little bit about some non-surgical management treatment options of some things that a lot of people might jump to the conclusion that they need surgery for. So I'm going to let Dr. Robyn give you a little bit more background about herself, and we'll take it from there.
Thanks. So first, I just want to say I'm at a skating rink today, so hopefully this isn't super noisy, but we're going to try to get through this without it getting wild and crazy. Because I don't work on Mondays, so I watch my kid. So my name is Robyn. I'm a primary care sports medicine doc. So that means I'm trained in family medicine and in sports medicine, so in non-surgical treatment of sports medicine issues. And so that's sort of how I got here. Yes, Carla and I met a long time ago. I think Lucas was like 9 or something, and doing some little extra strength training for gymnastics because his core needed it. And it turns out that he fell in love with weight training and things as a result, which was great. And now he's 15 and a half and a different sized human. Currently actually complaining about a little back pain, but anyway, that's another story. And unfortunately, we live a little bit too far away to come see Carla for that. So we're going to talk about knees and shoulders, and if we get to it, low backs too, sort of a broad kind of picture about non-surgical management of kind of anything, and then kind of the anatomy and common injuries that you might see on MRI of those couple of joints. And that's kind of the game plan today.
Awesome.
And I hope that you all can see this.
We are good.
Okay. So just sort of general principles of non-surgical management of pretty much anything. Your knees, your shoulders, your back, your whatever hurts. A short period of rest and gentle movement. This does not mean weeks and months of not doing anything. This maybe means a couple of days until things have sort of calmed down, and then starting to get things moving slowly, gradually, without sharp pain, maybe with a little bit of achiness, but just sort of getting moving. And then we're just sort of going to go in kind of a stepwise fashion from least invasive to most invasive potential treatment options. Over-the-counter medicines and topical treatments. So this would be things like your ibuprofen and Aleve. Also topical things like BioFreeze, icy hot, Voltaren gel, which is actually an anti-inflammatory, lidocaine patches, arnica gel, whatever it is you like to rub on things that makes them feel better. That would be sort of in this same category. Ice and heat certainly work in this category, and oftentimes that is enough to get you moving again. After that, we start to look at things like prescription medicines. Prescription strength anti-inflammatories might include meloxicam, diclofenac, Celebrex, or maybe oral steroids, depending on how severe your injury is. Some people can't take those because they're on a blood thinner or they have a gastric issue, but that's sort of our next step with medications. I like to use a lot of therapeutic movement. So that can be a physical therapist, that could be a chiropractor, that can be somebody who does, who has good training in biomechanics and kinesiology. After that, when that doesn't work, we start using additional adjunct treatment options. I say after mostly because insurance doesn't tend to cover those things as well. Not because they don't tend to help as much, but oftentimes your insurance will cover your physical therapist or your chiropractor, but they maybe won't cover your acupuncture or your dry needling as well. Cupping, iontophoresis, those might be in that same category. After that, we get to the stronger prescription medicine. So this is maybe your oral steroids, things like that. Then we start talking about injections. This would be steroid injections, or in the knee, this might be a gel injection or a hyaluronic acid injection or a rooster comb injection you've maybe heard of. Following that, we start talking about what insurance companies would call experimental injections. So this is PRP or stem cell or that sort of thing. The reality is these actually maybe work better and give you better long-term results for a number of different joint and tendon and ligament injuries. But unfortunately, insurance has decided that they would like to pay for steroid injections before they'd like to pay for PRP. So these tend to be all out of pocket, but they do tend to work really well. And then we like to try to get people gradually back to their activity. If all of those things don't work and all of those things fail, then we start talking about talking to a surgeon. And really sort of my goal in life is to try to not get to that bottom step, with the exception of sort of a very few findings on MRI or exam, or we failed all of these other things. I don't know, Carla, am I just supposed to plow through, or can people pop in and ask questions? I guess I don't know.
Yeah, people can ask questions. I'll probably pop in a little bit. If anybody else has questions too, you can leave them in the chat. I know some will
can I see the chat here?
Listen to it later.
If I'm sharing my screen, I guess I don't know. I've never shared my screen before. I feel very technologically advanced right now.
Yeah, if you hit the chat button down below and then you hit select to everyone, they can select it to come to you. And if I see anything Perfect. Come through the chat, I can facilitate as well.
Perfect. Okay. So maybe I will move on. So just a little bit of anatomy for the knee, kind of the big main structures. This middle business in here, that's your ACL. It's the thing that prevents your knee from sort of sliding forward and backwards on itself. The side ligaments on the side here and here, those are your collateral ligaments. They prevent your knee from bending side to side. And then these little cushions right here, those are your meniscus cartilage. And I think those are sort of a hot button on the MRI that we see a decent amount of. So I wanted to make sure we had a picture of sort of what that looks like. This is looking at your knee from the front, so we can't actually see the kneecap. It goes right here, but it's been cut off. So I would really like to move my picture of myself over there. Okay. So common things we see on knee MRIs. So ACL tear, if we see a complete ACL tear, so an ACL tear is generally an acute injury, like a cutting or a contact injury. This is going to be a surgical issue in an athlete who needs to continue to change directions or does a lot of significant lateral movement. So a soccer player, basketball player, a higher level tennis player, that sort of thing. You can see a degenerative ACL tear. So somebody who's had their ACL reconstructed in the past and who maybe their ACL has sort of degenerated over time, you can see that. But for the most part, an ACL tear is going to be an acute injury. In older folks like me, this can be a non-surgical injury. So a straight line athlete, somebody who walks, who runs, who lifts weights, who cross-country skis, who doesn't do a lot of cutting and pivoting activities, they might do just fine without an ACL, and truly so might other people. Troy Polamalu is fairly famous for playing his entire NFL career without any ACLs, and he did just fine, and his knees look great. So depending on how strong you are, you might be able to do just fine without an ACL, but a lot of times younger people who are still doing a lot of lateral and cutting movement will continue to want their ACL. So that might be one of the few things where you maybe want to actually see a surgeon pretty early on.
So that's an
Go
ACL
ahead.
interesting, Robyn. I tore mine
Mm-hmm.
2016. My dog took me out, and even competing at a professional level in CrossFit. I mean, you know, the surgeon I went to as well, and he said, well, I'll see you back when you want to repair it. And I haven't got to that point yet, but I think one of the biggest factors here, and correct me if I'm wrong, is if you do tear it, you got to stabilize everything else around it if you want it to be like a fulfilling thing for you in the future, right?
Absolutely. But that said, if you reconstruct it, you also have to stabilize it in order to be fulfilling in the future. So the reality is you have to do the rehab either way. So sometimes people are like, ooh, I don't know, that sounds like a lot of rehab to try to like be strong enough to keep my knee stable without having the ligament there to hold it in place. You still have to do that same rehab, whether you put the ligament in there or not.
Right.
And in fact, if you don't, that reconstructed ligament is just going to re-tear, and then you just went through a surgery that was kind of a waste of your time. So the fear of or willingness to do the rehab really shouldn't be your deciding factor. It really should be whether or not that ligament is a requirement for the activity you're doing. And I mean, in reality, CrossFit does not require an ACL. It requires a lot of strength, but it doesn't require an ACL to do those movements. So that's a good example.
Awesome.
So MCL, LCL, this is the ligament on the sides that prevent your knees from bending side to side. Usually you're hit from the side when you get an MCL or an LCL sprain, or maybe a twist. The nice thing about an MCL or an LCL sprain, if it's an isolated injury, these will heal in over time. Might take 2 weeks, might take 12 weeks. It depends on how old you are, depends on your activity level, depends on what you're doing. But I have been known to put a brace on a hockey player and let them play hockey in 2 weeks if they can do the things they need to do. A brace with hinges on the side, the hinges do the job of the ligament until the ligament is fully scarred in and healed like it needs to be in order to let the knee do the job that it needs to do. Rehab is important here to basically prevent you from getting atrophy of the surrounding muscles. So there is some tendency to sort of not want to use certain structures, whether that's consciously or unconsciously, when you have an injury. And so the rehab for the MCL and the LCL is not so much because it's going to fix the ligament, it's because it's going to promote you to continue to use your knee properly until your knee is back to normal. For the most part, I generally recommend that people wear a brace for the rest of whatever season they're in. If that's CrossFit, maybe there's not really a season. Maybe that's just until you feel comfortable. That might be 6 weeks. That might be 3 months. But if you're playing like in a softball league or a hockey league or something like that, you probably would want to wear a brace for the rest of that season.
And we have a question. Are the steps or order of assessment and subsequent treatments the same for youth and teens as adults, or do the steps vary based on age? And I think he's referring to kind of the steps in your previous slide about kind of the hierarchy of that direction.
Yeah, pretty much. Pretty much the same for youth and teens as compared to adults. There are some caveats to that, and I'll talk about that a little bit with meniscus and maybe with shoulder dislocation a little bit. There are some things that you might be quicker to consider surgery in a younger person because you might be able to return their joint to normal joint status. Whereas somebody who's 40 something, their joint is already what it is, and it's not really going to get any better than it is. I'm not sure if that answers the question, but for the most part, it's basically still the same. So if we look at a meniscus, the meniscus is the cushion that you stand on. So it's sort of your shocks of your car. In a young person, that tends to be more of an acute injury. They twist and they tear. In an adult, sort of 35 plus. That tends to be more of a wear and tear or a fraying more often. You can get an acute injury, but oftentimes you have some degeneration and fraying to begin with, and then you twist and it tears more. The meniscus loses its blood flow in your early 20s. And so it becomes sort of dry and kind of easily cracked and torn. So when you're young, when you're a teenager, early 20s, you can actually sew a meniscus back together. So this is where I'm saying you might be quicker to see a surgeon as a young person for a meniscus tear, because it's possible that if it's in the right place and if you're young enough and you still have blood flow to that area, you might be able to actually restore that joint back to normal and hopefully prevent early progression to arthritis. Whereas if I tore my meniscus, that's not going to be able to be sewn back together. It's not going to heal back together. So the trial of medicine, rehab, maybe an injection, maybe some more medicine, and then maybe go see a surgeon is going to be the more common route and the smarter route for meniscus tear. Maybe 10 years ago, we used to do arthroscopy on meniscus tears all the time. 20 years ago, all the time. We just went in and basically scraped them out and said, well, now your knee feels great. You can go do whatever you want. Unfortunately, when we do that, we find that people progress to total knee joint replacement much faster than people who don't have a meniscectomy or scraping out that little piece of frayed meniscus. So if you can avoid surgery, that's better for your knee. If you can't, if your knee is locked, if your knee continues to buckle, if you try rehab, you try medicine, you try an injection and nothing's working and you're still stuck with a swollen knee that bothers you every couple of weeks or every time you try to squat or every time you try to do something, certainly yes, surgery is an option for a meniscus tear, but understanding that it does present you with an increased risk of surgery as your knee ages. Questions about that one? That's kind of an age difference on that one.
No, that's great perspective. Thank you.
Okay. Oops, too fast. Okay, so the shoulder. So kind of a basic picture of a shoulder. Up here is the collarbone. Back here is the shoulder blade coming in from the back. There's the arm bone. These muscles here are all different muscles of the rotator cuff. They all come up and under the shoulder blade and the collarbone, and they attach on the humerus or the arm bone. Underneath the rotator cuff is the labrum, or the gasket kind of piece of cartilage that sort of holds the arm in place. If the capsule or the labrum is loose or torn, the rotator cuff has to do more work to sort of hold it in place properly. So talk about a few things here. So a full thickness rotator cuff tear. This is commonly an acute injury. You fall down the stairs or skiing or what have you. Or it can be a wear and tear and age-related phenomenon. Our rotator cuffs were really only meant to do somewhere between 40 and 60 years worth of work. And as the rotator cuff sort of runs underneath that spot below the collarbone and the shoulder blade, it kind of frays like a rope, and over time sometimes that will just snap. If you fully tear your rotator cuff muscle, it will not heal. It won't come back together on its own. You're just stuck. It came all the way apart. The rubber band has snapped. Most of the time this is going to be a surgical issue, with the exception of significantly older folks or people who have significant medical issues that make surgery and recovery difficult, because recovery from a rotator cuff surgery is a big deal. So somebody who maybe wouldn't get a rotator cuff repaired might be, you know, an 85-year-old lady who lives in a nursing home, or somebody who really doesn't have to reach up above their head anymore. They could reach with their other hand, and then this arm only goes sort of horizontal. And those folks will use rehab and medicine and that sort of thing, but they will lose some of that motion. So not fixing that rotator cuff tear, there is a loss of function in that arm for sure. A partial tear, on the other hand, or a sprain, so anything less than 75%, give or take Some surgeons will let you try to rehab a 90% tear, and some will say 50%, oh, let's fix it. It's just never a surgical issue. It's always a rehab issue. It's always lots and lots and lots and lots of rehab. And then do the other things for your pain, for your swelling, for your comfort. So the medicines, the dry needling, the injection as needed. A lot of times this is a lot about activity modification. So particularly like say for CrossFit, if you have a partial rotator cuff tear, a lot of sort of overhead behind the back kind of activity is going to be particularly painful for a rotator cuff injury. That doesn't mean you can't do anything else with your shoulder. It just means that getting sort of back here in kind of an overhead press position is painful, but you can do a whole lot of other things. So a lot of times it's just about activity modification while you're rehabbing that injury. A labral tear, so the labrum is that cartilage gasket that holds the arm in place underneath the rotator cuff. This can be an acute injury or a wear and tear injury. Acutely, it's usually a shoulder dislocation. So the shoulder pops out and it comes back in, and that tears that capsule or gasket. Acutely, if that happens in a young person, they are doing some studies right now about early surgery for a labral tear in an athlete. So younger athletic person who has a clearly acute labral tear or shoulder dislocation, that is worth an MRI and talking to a surgeon about risks and benefits of what that will do. Surgery for a labral tear tightens your shoulder. So if you happen to be a more mobile athlete, somebody who swims or plays volleyball or does gymnastics or does CrossFit and likes lots of mobility with their shoulder way back here, you might not like surgery for your labrum because your shoulder will be tighter afterwards. But there is some new emerging research about early surgery for labral tears. That said, we see Major League Baseball pitchers who pitch their whole professional career without fixing their labrum. And I don't know if it's good enough for them. It's probably good enough for me. Labrum also do degenerate and wear and tear both in the shoulder and in the hip. We're not talking about the hip today, but they do degenerate in the hip as well. So a little bit of fraying here and there. Sometimes you get in a funny position and that fraying will sort of pick up, and that will cause swelling and pain and get in your way. That tends to respond really nicely to those other things, the medicine, therapy, injection. And then sometimes they'll go in and clean it up or tighten up the labrum if you're not responding to those other things well.
Yeah, I'm pretty sure that probably 50% of professional players I work with either have a partially torn rotator cuff or labrum, just an ongoing managed thing, and they're playing at the top of the world. So
right.
I think that's just something in perspective too. But they also put in a lot of time and energy into their rehabilitation. And it's not just like they do it for 2 weeks. It's like they do it for their life.
Right. These are very much maintenance issues.
Yeah.
I don't know if we have enough time to talk about the spine. Do you want me to talk about this quick or no?
Let's talk about it. I think it's important.
Okay.
And I mean, a lot of people deal with it. So yeah.
So quickly, lumbar spine. So here's a little picture of kind of your discs, where your nerves come out through the side. This part here, that's your facet joint. And this part here, that's where you get a spondylolysis. We're going to talk about those things. So I just wanted to kind of show a little picture. Okay. So disc bulge, protrusion, herniation, whatever it is you want to see, disc degeneration, whatever, on an MRI. So yes, you can have an acute disc injury. You can bend over, pick something up, your disc pops out the back, and all of a sudden you have sharp shooting pain and it goes down your leg and it's the worst thing ever. You can also have wear and tear that causes sort of progressive disc degeneration or herniation, or this can be a normal finding. So depending on the study that you read, anywhere from 30 to 60% of 40-year-olds will have an asymptomatic abnormal disc on their MRI, meaning they have nothing that bothers them on exam, nothing that bothers them in their life, and up to 60% of them have some abnormality in their disc. So just because you have something abnormal in your disc on your MRI does not mean that you have to do anything about it or that it's even the cause of your pain. So I think that's really important to remember. The abnormal disc or abnormal anything on your MRI has to actually correspond with where you hurt and how you hurt and when you hurt. Sort of general guidelines for disc issues. And certainly there are some that are bigger and worse and some that are smaller and less bad. But if you sort of put all comers together, about 85% of disc problems will improve with just medicine and rehab, whether that's the lower strength anti-inflammatories or the higher strength oral steroids, medicine in general, and physical therapy, chiropractic, however it is that works for you is fine. Of the remaining, of those 15% that are left, about 85% of those will get better with an injection. So an epidural steroid injection to try to basically direct that steroid kind of right at where the disc problem is and get that disc to kind of shrink back up to where it belongs, which leaves less than 5% of disc problems, of all comer disc problems, to be a surgical problem. And I guess personally, as somebody who has a whole heck of a lot of back problems, less than 5% of disc problems wind up needing surgery. That's fairly reassuring, really. So keep that in mind when you're getting your MRI. Most people don't actually need back surgery. Another thing in your MRI, I'm going to go back here quick. This joint right here, this facet joint. So basically your spine bends back and that joint rubs against itself as you arch back. You can get arthritis at that joint. Facet arthropathy is what that will say on your MRI. Oftentimes this starts younger than people expect. Like you'll be 35 and you'll say, what? I have arthritis? Yeah, a lot of us start in our 30s. This is pretty rarely surgical. It's really very rarely surgical. Lots of times medicine or an injection works really well. There are some really interesting laser things that can be done with the facet joint. Radiofrequency ablation is an option. So there are lots of good things there. Honestly, one of the biggest things for facet arthropathy is activity modification, making sure that you have good squat technique, making sure that you're not loading your spine incorrectly, making sure that you're holding a squat bar correctly, or maybe you shouldn't have a squat bar on your back. Maybe you should be front squatting, or maybe you should be dumbbell squatting, or something else. But a lot of times facet arthropathy can just be treated with activity modification after that sort of short acute period right at the beginning when it's hurting you. And the last one that I just briefly want to touch on is spondylolysis or spondylolisthesis. So spondylolysis is a stress reaction or stress fracture. Spondylolisthesis is actually when the vertebrae shifts as a result of that stress reaction or stress fracture. So you have these little wings right here. They hold your vertebrae in place. If you get a fracture in one of those, your vertebrae will actually slide forward. The stress reaction or stress fracture is generally treated with rest and then activity modification and good rehab back to sport, but usually takes between 3 and 6 months. A listhesis, or actually a shifting, can be more significant. It can take longer. On rare occasion can be a surgical issue, but this is something that's more significant that really should see somebody who's trained in spine or in sports medicine who's familiar with spine, so that you make sure that you're getting the right return to activity. That's kind of the, I don't know, most significant thing that you might see on your MRI. We see a decent amount of those in extension-based athletes, so people who do gymnastics, wrestling, dance, weightlifting, offensive linemen. So that's briefly on the spine.
And you might know the most recent statistic, but is it still about 10% of athletes will have a spondy?
Yeah.
Okay.
Yep. So about 10% of adolescent athletes.
Correct.
Yep.
Yeah, back in school when we first
I'm 43 and I'm still an athlete, right? So
correct. Do you work out on purpose?
Right, on purpose. I get sweaty.
I exercise on purpose. That quantifies us as an athlete.
Right.
Um,
Totally.
The other interesting thing about spondies, like way back in the origin, if you had one, they literally made you stop doing anything until they started learning more about them. But it was like a doomsday, which people, like some of our highest level athletes in the world, have them. It's not an abnormal finding, I guess.
No, and it was kind of sad because it was like the end of everything. And so sometimes I'll see people and it's like, well, that means they have to quit, right? Like, no, it doesn't mean they have to quit. I mean, it's hard. Rest is hard. Rehab is hard. It's frustrating, but no, it doesn't mean you have to quit, but it means you have to get smarter about what you do.
Yep.
And sometimes, unfortunately, it's the first injury that an athlete runs into, and it's a big, icky, hard thing. Kind of like if the first injury you have is an ACL tear, well, that's a big, icky, yucky thing to deal with. But honestly, you might get back faster from a spondy than you do from an ACL injury. So I don't know, that maybe puts it into perspective.
Right. Yeah.
I have one more slide.
Yeah.
So a lot of times, like the big question that I have is, well, won't I make it worse? I mean, I should do surgery so that I don't make this worse. And almost never is surgery the thing that's going to prevent you from making it worse. So your joints are meant to move. That's the thing they're supposed to do. Your injury might require that you modify your movement for a period of time. It might even require that you modify your movement forever. I can no longer max squat with a bar on my back. I can't feel my right leg when I do. I can squat with a bar on my back, but I can't max. I just can't. It's not a thing that my spine can handle.
Yep.
That's just a bummer. But that doesn't mean I can't squat. It doesn't mean I can't max squat. It just means I can't do it with a bar on my back. So there are ways to modify your life and still enjoy what you're doing.
Yep.
Moving an arthritic joint actually releases certain chemicals. We're not going to talk about TNF alpha and whatever else, but it releases chemicals that improve pain and that lubricate cartilage. So those are good things for arthritis. Proper movement of injured tendons and ligaments actually reorganizes injured cells, puts them back into the correct alignment, and actually makes them work properly. So moving arthritic joints, injured tendons, injured ligaments actually causes healing. So just sitting there and doing nothing in a sling or a splint or whatever is not actually helpful. Yes, if you have a broken bone, you have to immobilize it. But beyond that, for the most part, movement is healing. In general, I hear a lot of like, well, I don't want to put those medicines, in my body, like there's side effects. The risks of short-term medicine or even long-term every day for the rest of your life, arthritis medicine or treatments or injections are almost always less than the absolute risk of a surgery, of anesthesia, of an infected joint, of those sorts of things. Yes, everything has a risk. You could just do nothing. That's an option. And certainly that's always an option. But if you want to do something, generally the risk of a medicine or dry needling or rehab or an injection is going to be less than actually cutting your body open. And a surgeon will never guarantee you 100% improvement in pain and function. Never, ever, ever will a surgeon tell you for sure that they can fix you. Neither can any of this, but it's worth trying first. So.
Yeah. I also think an interesting thing in surgical medicine is that a successful procedure is done when the patient recuperates out of surgery and the tendon or whatever is adhered, fixed, whatever they did. But that's how a surgery is considered successful. It isn't a 3-year, 5-year post-op follow-up is to the athlete, in our cases, the athlete's version of success, right? So everybody has a different picture of success. And I think, especially when working with your sports medicine providers, whether that be chiro, PT, massage, MDs, like having the athlete's goals in mind too, and working with them. I think that's why I gelled so well with you, because you're like, well, here's option A, B, and C. Which one sounds the best kind of for your thought process and your goals? I mean, I think somebody that'll work with you is a key for that.
Absolutely. I just saw a kid the other day, high level gymnast, who ended up having wrist surgery just on a kind of a no big deal wrist thing, but ended up having surgery. And the surgeon, came and asked me, he's like, well, this kid's coming back and I don't really know, like, they say she doesn't have good extension and like, it looks pretty good to me. Like it's, pretty good. And I said, well, she doesn't have good extension for a gymnast. She's a national level gymnast and she can't tumble back on her hand all the way because she can't get it all the way back. So to her, she is limited still. She wants to know how long she's going to be that limited. And he's like, well, I don't know. He's like, well, she can do that. And I'm like, right, this hand goes like this. And this one only goes like, she wants to know how long it's going to take her to get back there. As long as it takes her. That's not the answer that, and going into surgery for her, the outcome goal was do all the things I can do. And he's like, well, she can swing on the bars and it doesn't hurt her. Right. But she can't do 100% of the things you told her she was going to be able to do. So now she feels like she's missing. So, understanding that surgery doesn't necessarily provide those goals either. And looking at, okay, what are all the other options that I can try? Do I actually have to cut myself open? And will it actually make me any better than all of these other things that I'm doing that I enjoy doing? How long is the rehab going to be from that? What am I going to miss out on during the rehab from this? And then making those decisions. At this point in my life, would I ever fix my ACL? God, no. What would I do with that? I even figure skate still some, but like I don't do enough on the ice to necessitate an ACL. And I sure as heck don't need a 9-month recovery from an ACL surgery. I need, like a 6 to 8 week ACL rehab PT program and then continue to do my exercises. That's probably what I need. But, if my 12-year-old tore her ACL, that's a different question altogether.
Yep.
So.
Awesome.
Well, does anybody else have questions?
Yeah.
Before we go? I feel like we kind of flew through that in about 2.5 seconds. So
I think you gave 9 really targeted top question injuries and ailments that people tend to jump to that conclusion to. So I loved your choice of those injuries. Thank you.
Mm-hmm.
And we'll be looking forward to maybe a few months down the road to getting some more of your input. I know we talked about some other fun, interesting topics to discuss with you. But yes, from EHP Performance, I just wanted to thank you for being on our Healthcare of the Future talks and helping forge EHP Performance forward.
Great. Thanks, everybody.
Yes, have a great day.
Bye. So I should stop recording. Stop.